Assalamu alaikum. Let's dive into fetal demise. Okay, this is a very high yield topic taken from USML Inner Circle. Okay, intrauterine fetal demise. What does it mean? Absent fetal cardiac activity. Absent, absent fetal cardiac activity more than 20 weeks of gestation. That means absent fetal cardiac activity after 20 weeks of gestation at or 20 after 20 weeks of gestation, so absent cardiac activity. So intrauterine fetal demise first causes aneuploidy, fetal or placental anomalies, fetal growth restriction, congenital infection, substance use like cocaine, tobacco, maternal condition like hypertension and diabetes, maternal condition like hypertension and diabetes. So aneuploidy, then fetal or placental anomalies, fetal growth restriction, congenital infection, substance use, and maternal some condition. How will you evaluate? You can evaluate by a fetal autopsy, gross or microscopic examination of the placenta and the umbilical cord, and karyotype or genetic study. So autopsy can be done, growth and microscopic examination of the placenta, growth and microscopic examination of the placenta and the umbilical cord, and karyotype genetic studies, karyotype or genetic studies. For it is for fetal and for maternal. Clay who are Betke test, antiphospholipid antibody, anti-Rho, anti-La, and the coagulation studies. Clay-Horr Betke test, a maternal blood smear is exposed to acid and stained afterwards. So maternal blood exposed to acid, exposed to acid and then stained. An adult hemoglobin is removed by acid, whereas fetal hemoglobin not, resulting in pink color that indicate fetal hemoglobin on a positive test. Okay, how do you diagnose the fetal demise? You diagnose the fetal demise by Kleihor or Batke test. So maternal blood smear is exposed to acid and stained afterwards. Adult hemoglobin, we know that adult hemoglobin is removed by the acid, but the fetal hemoglobin is not removed by the acid, resulting in pink color that indicates that fetal hemoglobin or positive tests. Women with unexplained late term, women with unexplained late term should undergo weekly non-stress testing. Women who unexplained late term stillbirth, weekly non-stress testing in the third trimester starting 32 weeks. So history of unexplained stillbirth should undergo non-stress testing in the third trimester. Even after thorough evaluation, up to half of the intrauterine fetal death have no identifiable cause, therefore should be consult in advance and that testing may be negative. Intrauterine fetal demise, fetal death more than 20 weeks, absent of fetal cardiac activity on ultrasound, 20 to 23 weeks. If it is 20 to 23 weeks, dilatation and evacuation or vaginal delivery. If it is more than 24 weeks, vaginal delivery. Complication coagulopathy after several weeks of fetal retention. So cesarean delivery by maternal choice if history or prior classical cesarean or myomectomy. Induce vaginal delivery when mother is ready. So cesarean can be done if mother wants to. But induced vaginal delivery, if mother wants to have caesar wants to have this delivery. Okay, delivery planning for a non-viable fetus, fetal diagnosis. Delivery for a non-viable fetus if there is anencephaly, if there is bilateral renal agenesis, if there is acardia, no heart, no fetal head, no kidney, bilateral renal agenesis, if there is hollow prosencephaly, if there is thanatotrophic dwarfism, if there is intrauterine fetal demise. Obstetric management is vaginal delivery, no fetal monitoring. Mm, and neonatal management is palliative care if stillborn. Palliative care if stillborn. So for intrauterine fetal demise, you have to remember 20 to 23 weeks vaginal dilatation and evacuation or vaginal delivery. If more than 24 weeks, then you should do for vaginal delivery. And coagulopathy after several weeks of fetal retention. So cesarean delivery can be done if mother wants to. Development of DIC requires urgent delivery of the fetus via vaginal or cesarean delivery. What is the recommended management for a pregnant woman? Recommended management for a pregnant woman at 28 weeks of gestation that presents in labor for a fetus diagnosed with anhydramnios, no anhydramnios and anencephaly. The fetus is breech presentation. So anhydramnios and anencephaly fetal is breech presentation allow for spontaneous vaginal delivery. The priority of the The priority for patients with lethal fetal anomalies anencephaly is to minimize the maternal morbidity and mortality. C-section has increased risk of maternal complication. A breech presentation is a lethal in lethal anomalies does not require C-section. Breech presentation in lethal anomaly does not require C-section. Vaginal delivery is preferred due to increased risk of maternal complication associated with C-section. What is the next step for management of pregnant woman at 25 weeks of gestation? Pregnant woman at 25 weeks of gestation presence after feeling no fetal movement for past 2 days. No fetal movement. Fetal heart sounds are not heard on Doppler. You should do transabdominal ultrasound. The patient is likely intrauterine fetal demise, fetal death more than 20 weeks. If fetal death more than 20 weeks, it is called intrauterine fetal demise, which must be confirmed by the absence of fetal cardiac activity on ultrasound. Because patients blame themselves for because parents may blame themselves for the baby's death, it is important for the physician to respond with a clear statement that it is not their fault and there is nothing they could have done to prevent the loss. The physician should also avoid prematurely changing the focus of the discussion to medical management and reassurance, uh, medical management and reassurance for future pregnancy, referring to the fetus as their baby and avoiding medical terminology fetal demise are helpful. Okay, now hydros fetalis. Look at these baby hydros fetalis. Increased cardiac output demand causing heart failure, increased cardiac output demand causing heart failure, and increased fluid movement into the interstitial space, third spacing, increased fluid movement into the interstitial space, that is third spacing. Clinical feature is pericardial effusion, pleural effusion, all the fluids in the heart, lungs, in the abdomen. There will be skin, maybe skin edema, placental edema, polyhydramnios. Everywhere fluid comes. Immune is Rh alloimmunization and non-immune. Non-immune is parvovirus B19 infection, fetal aneuploidy, cardiovascular abnormality, and thalassemia. And it can cause high output cardiac failure. Okay, if we look at this stem, in here the uh, baby has died, 32 weeks of gestation. There is intrauterine fetal demise. So what what should be our response? So our response should be sympathetic, and we should tell that if she wants to know the cause, we can do further testing for knowing the cause, but sometimes intrauterine fetal demise, we may not know the cause. Look at this line: no identifiable cause, even though after thorough evaluation, up to half of the intrauterine fetal death, there is no identifiable cause. Okay, if we look at this stem, this patient, 34 weeks of gestation. If we read this patient, she has miscarriages at 8 weeks of gestation. There is another history. Then in ultrasound, there is a singleton of fetus with a normal anatomy and no fetal cardiac activity. 34 weeks, no fetal cardiac activity, looks like intrauterine fetal demise. And she has a history of miscarriages. First two pregnancies were ended in the miscarriages. So looks like it is antiphospholipid antibody syndrome. It is the uteroplacental artery thrombosis, and it is stillbirth or intrauterine fetal demise due to antiphospholipid antibody syndrome. And in antiphospholipid antibody syndrome, there is uteroplacental insufficiency, impaired fetal oxygenation, nutrient supply, and thus causing this fetal growth restriction. Okay, if we read this question, there is what? Hemoglobin low, there is okay, ultrasound of the male fetus, there is edematous scalp, so scalp edema, large amount of fluid, there is amniotic fluid is higher, placenta thickened, everything is higher. Okay, it may be alpha thalassemia measure and looks like hydros fetalis. If you look at this picture, looks like it is hydros. When there is everywhere is fluid, think about hydros fetalis. Okay, the last thing I want to make you learn, like if you look at this question, in here, although it is hard decision, a fetal autopsy and placental evaluation may help us and assess the future risk more clearly. So we can do testing, we can, but sometimes even if we do the testing, we may not be known the cause of the intrauterine fetal demise. So that's it for intrauterine fetal demise. Hope you enjoyed. The previous name is stillbirth. Okay, thank you.